Okay. Well, thanks everybody for coming. So like I said, this is completely optional. I'm glad that you guys are here. There's no strict format that we have to do for this by any means. I figured it'd be a nice time if you have questions to let me know. A few people did email me some questions that I'll go over. Otherwise, I have things that we can discuss. So this is completely what you guys want it to be. I just want it to be helpful for you. So if we want to start, does anybody have questions, concerns, or thoughts?
I just have a general.
Sure.
This exam is from lecture 6.
So if that's anxiety disorders, I can't remember the numbers, but
yeah, I think it is.
Yeah. Yep. Except for this week, it doesn't include personality.
Okay, I also had a quick question.
Yep.
I have been typing notes along with the lectures. Am I going to be able to use that with the exam, even though they're typed?
So that's tricky. The purpose of handwritten notes is because there's something that helps with memory by transferring that to paper. So the only way I'll allow type notes if you are printing like the PowerPoints that I give, and if you handwrite notes on that. But if it's just simply typing everything, then you'll have to condense that down a little bit.
Okay.
Does that sound okay? Okay. Other questions? Any other logistical questions about the exam? What it's going to look like, note taking, honor lock, anything like that?
I don't have a question, but I know last time when I took it, I was super nervous. And I cleared out my house. I had everybody gone. It was quiet. And then I heard my gate rattle like 10 minutes before it was due. And I was like, oh no, somebody's going to come and I'm going to get in trouble. And so I like submitted it because I was done, but I wanted to like review it more. But I thought, and it was like my cat jumping over the fence. And it made me like submit it. So, but it was interesting to be on there.
Yeah. And so just so you know, like, I understand that there's going to be background noises and things are going to happen. That is not going to fail you by any means. The only thing that it'll do is just notify you that there was maybe some type of disturbance. And as long as it wasn't like somebody coming in during your test, right? Like that's going to be fine. So like, you can still have your phone. Obviously don't use it. You can still, if you have pets around, that's completely fine. It's just to ensure that someone else isn't helping you and you're not accessing like everything on the computer. That's it.
Yeah, it made it really intimidating when you read the reviews. And
yeah,
I was like, oh, I've never done this before.
I know there's pros and cons to it. It's just, that's kind of the easiest way to ensure test security at this point. But like I said, I get notified on anything. And if you have concerns, just let me know, but don't view it as like this really intense thing. Like it's basically just recording you and that's it.
Okay, cool. That's good to know.
Yeah.
Thank you.
Of course. Anything else related to exam, like as a whole? Okay, you'll still have 75 minutes. The notes will be really helpful, but make sure to study those because there's still going to be a short answer question at the end and that will take some time. So just make sure that you're not only relying on your notes. You'll still need to know the information, but I do think it'll help at least alleviate a little, stress that you're experiencing related to this. All right, so moving forward, anybody have questions that they want to throw out there? Otherwise, I can go through questions that I received.
So off of the quizzes, were there certain ones that you see predominantly missing, or you see like a pattern of people missing that we could go over? Or?
It's a good question. It really varies week to week. And since I'm not testing you weekly on the material, it's kind of hard to know. But a lot of them are, where it's really close. Like the answer choices are really close, whether it's like increase or decrease or this neurotransmitter versus that. So it's just being able to differentiate those as much as you can. That's kind of the biggest area that I'm seeing. But I haven't exactly examined like item analysis for quizzes. I do for exams, but I can definitely take a look at that and then let you guys know if I see anything too. Sorry, I know that's not super helpful, but there's a ton of variability with the answers right now. Most people are doing pretty well though.
Okay.
What else?
I don't have any other ones. So if anybody, I think we could go on.
No question is dumb. So if you have something, throw it out there, or if you just have a topic you want to go over in detail. Like I said, I do have some stuff prepared, but I don't want to just be talking at you the whole time either. I don't want that to, be so overwhelming. So just let me know. All right, well, I'll start with one question that I got. Let's see here. So one question that I got was regarding etiology of schizophrenia. So generally, how do you all feel about knowing kind of the etiology with that? You can even just use reactions if you want, like down, thumbs up, thumbs up, maybe a little. Okay. So I'll give you some hints on kind of what I'm looking for in this exam. So it's kind of broken down into these three big areas, right? So it's biological, psychological, and sociocultural. So the first one with biological, just on its most basic form, just know that, genetics are involved, that there's multiple genes. And even though schizophrenia can be inherited, it almost seems like there's just this general predisposition for the disorder. And so knowing that just on its most basic level will be really helpful. And then taking that a step further, so neurotransmitters, so dopamine hypothesis. Again, this is just saying that people with schizophrenia have an excess of dopamine. That's important to know. But just know that that only explains the positive symptoms. So that's things like delusions, hallucinations. It doesn't account for negative symptoms. So then the next thing with biological is the neurodevelopmental hypothesis. And this basically just says, something happens to the person really early in life, and then that can either be like prenatal. And so that's things like oxygen deficiency or, nutritional deficiency, the mom having influenza, things like that, or during birth, after birth, and then that disrupts the brain's development. So essentially like the brain the disease develops across the lifespan. So that kind of explains why schizophrenia tends to manifest later, is because it takes the brain that long to kind of develop in that way. We all on board biologically? That's kind of the basis you need to know for that. Okay. Someone speak up if I'm not. All right. So next, if you think about it in terms of psychological, we're going to go right back to the diathesis stress model. So this is similar to what we saw in exam 1. So somebody has an underlying vulnerability, and it's typically biological in this case, but it doesn't have to be. And then this disorder is, expressed later once they experience some type of stress. So basically at its most simplest form. And then the only other psychological one that has evidence for, because, I talked about like marijuana in the lecture and, things with, bad moms, things like that. There's no evidence for that. So focus on the ones that do have evidence. And the other one is just expressed emotion. And so this is basically saying that, only in family environments that schizophrenia is implicated is when families are high in this, which basically means they're critical, hostile, over-involved in somebody's life. And that can help, maintain schizophrenia. It doesn't necessarily cause it, but it can be that stressor that would maybe be there for the person that has that predisposition. So those are the two big things for psychological. We all good so far? Let me know if I'm going too fast. Okay. All right. And then last is sociocultural. And so this is, this is probably the one that you're going to need to spend a little bit more time on because I've introduced some new hypotheses with this. And so One is just urban environment, and that's just saying that people who live in this urban environment are at a higher risk compared to people with, you know, from a rural environment. So that's just a risk factor. Same with immigration. Being an immigrant risk is also increases that risk, but this is likely to just experiencing like discrimination or stress. It's not because they are an immigrant. And then low socioeconomic status. And so within this, there's two theories. And so these ones definitely know the difference between these two. They're going to be on the exam one way or another. So just focus on these two. So social causation hypothesis, this, you know, it could be that growing up having low SES causes schizophrenia because it's more likely that that person would experience stress and discrimination. So this is like a causal explanation for it. Whereas the downward social drift hypothesis, it really doesn't matter what SES one grows up in, but just that once someone starts experiencing, you know, schizophrenia or symptoms related to it, they're more likely to move into that lower SES category. So just basically knowing that this downward social drift hypothesis is explanatory versus social causation is actually, you know, positing that there's a causal link here. So those are the big two. And so, like I said, those two are definitely going to be on the exam. Know generally what how they are alike and how they're different. But like I said, spend the most time probably on that section. Questions on schizophrenia? Feeling okay about the etiology of that? Because there's a lot that goes into the development of schizophrenia.
I thought that was...
Okay. All right. Yeah, thanks for using the reactions. That's helpful. All right, any other questions? Oh, so for schizophrenia as well, know the gender differences, know age, onset. Generally speaking, for most disorders, try and have like a general idea of, you know, who might experience it, who's at greater risk, and kind of likely when it develops. But for sure, schizophrenia, know that because that's a big one. Okay. So I didn't get a lot of other questions. I got 2 questions on that. So again, going to open the floor. If anybody has questions on, doesn't even have to be schizophrenia, but other disorders or concepts that I've covered. Otherwise, I'll just go over things that I've pulled that you should make sure you review.
Okay, so like how in depth are you going to want us to know like the etiology of all the disorders that we've covered so far?
Just generally speaking. So if there is, you know, especially with like psychotic disorders, I only go into etiology for schizophrenia. So that's the only thing you have to focus on for those. Otherwise, let me just take a look at my notes regarding it.
Like prevalence and stuff for
Nope.
the disorders?
Nope,
Okay.
You don't need to know that. That's just kind of to help you conceptualize things more. The only thing related to that, like I said, is like gender differences and age of onset, that kind of thing. Okay. Yep, you don't need to know prevalence or incidence rates.
And then as far as like the criteria and stuff are concerned, are you just wanting us to know like the differences between them, or are you going to want us, I don't know, like, because some of them, you know, have like, there's only 2 of these ones and you need 1 of this one and like all that. I don't know how much of that you want us to cover.
Yeah, there's a ton of criteria. And, you know, I've been using the DSM for numerous years and I still have to reference criteria. So I would never ask you guys to memorize that. So what I'm looking for in that is like a really good example is acute stress disorder and PTSD. Acute stress disorder looks exactly like PTSD, except for like that time duration piece and disassociation. So that's the kind of question I would ask. Like, how would you separate these 2 disorders since there's so much overlap? And so definitely know that one. I mean, that's a major hint right there, but that's the kind of stuff I'm looking for, is just being able to generally know what kind of symptoms comprise a disorder. And if there's a ton of overlap, especially when we see like anxiety disorders, that kind of thing, knowing like that one thing that might separate it. Okay. Good question though. What else? Yes, I'm releasing the quiz answers tonight. I was just waiting for 2 more students to take it. So it'll be released tonight. All right. Anybody else have things they want to throw out there? Are there certain disorders or sections, you know, on lectures that are more difficult, would you say, or are they all kind of equal to you?
I had another question actually, and I can't really remember what the 2 disorders we were talking about, but 2 of them had delusions, and one of them was like really drastic delusions, and the other was like almost believable delusions. What were those 2 disorders?
Let me see if I can. Quite a few disorders can have delusion. So let me see if I can figure out exactly what you're talking about.
I think we just talked about them in the last lecture. It might honestly just be like schizophrenia and delusional disorders, but
yeah, that's probably it. Give me 1 second. Okay. Yeah, because you know, delusions are one of the most common symptoms in schizophrenia anyway. Like I said in lecture, 90% of people with that disorder have some type of delusion. But delusional disorder, that's where it kind of takes the entire thing, right? Like that's where you're going to want to know the different types of delusions that they're having. And so really know those different types, like persecution, grandeur. Let me see, I'm going to let somebody in. Just to answer the question in the chat, yes, so this is anxiety through psychotic disorders. But so on the exam, there's going to be questions related to the different types of delusions. So that's kind of what I was getting at. There's going to be examples of here's a really fixed belief, and what does this kind of resemble? And so just make sure you know the difference between, you know, delusions of control, delusions of reference, persecution, and grandeur. Those are the big ones. But then also kind of broadly knowing what thought broadcasting is, thought insertion, and thought withdrawal. So those are way less common, but just be able to know, like, generally speaking, what would that look like? Okay. Let's see if there's anything else. I want to make sure I note on delusions quick. I'm trying to, because there's a lot of information here, right? So I'm trying to give you really targeted information to study. So, which is why I'm referencing my notes, because otherwise we could have hours long conversation about these things. So let me just double check here. All right. Okay. Other questions related to delusions or schizophrenia, psychotic disorders in general?
Did the schizophrenia form, does it have delusions in it as well?
Schizophreniform?
Yes.
So it can. The big thing to know with schizophreniform is that they basically have all the same symptoms as schizophrenia, except the time duration is shorter. And so that's basically what you're going to look for. So it's going to be for at least 1 month, but no longer than 6 months. So it's really going to resemble it. It's just schizophrenia is kind of this lifelong thing, right? Where schizophreniform is a lot shorter duration.
Okay.
Good question.
On schizoaffective disorder, so when you've got the mania and you have the actual schizophrenia criteria that you're doing, how do they, like, how in depth are you going to get in with that on the test?
Not super in depth, because schizoaffective disorder is one of the hardest disorders as clinicians to even diagnose. So I'm not going to make you guys know much about that. So just its most basic level.
Okay.
Just knowing that that mood component is there.
Because that would be, holy Toledo, so hard to figure out.
Yeah. Yep, exactly. You know, that's exactly why I said that in lecture, is that even for us, this is a really hard thing to diagnose.
Mm-hmm.
You can, if you have other stuff, you can keep throwing it out there. Oh, to go back to the question about the kind of true delusion. So in delusional disorder, I don't think I answered your question now that I think about it. They are often non-bizarre. So they could be really real. So that's kind of how that separates. For delusional disorder, that's why it kind of manifests that way, is because it could be something that we could all experience. So kind of look for that when you're trying to differentiate between somebody with schizophrenia who's having delusions versus delusional disorder. Yep, psychotic disorders are on this exam, just not personality disorders.
So with the disorders that we covered that have like specifiers with them, are you going to want us to know those specifiers on the exam?
No, not generally speaking, just because those are pretty consistent across disorders a lot of the times. The only thing that I would maybe recommend knowing is, like, you know, predominant pain specifier, what disorder that goes with. Otherwise, I'm not really looking for specifiers at all.
Okay.
And like just generally knowing the difference between a hallucination and a delusion. So there's going to be like examples on there describing symptoms that somebody experiences. And so it's not going to be like a hallucination is what? It's going to say, you know, Mike is experiencing XYZ. What is this? And so be able to identify, like, is that a hallucination? Is it a delusion? There's going to be questions on that. Everybody feel okay about the difference between the two? It's okay if you don't yet, you still have time to study, but okay. Otherwise, if you need me to review it, I can. Does everybody know what tardive dyskinesia is?
I do, but I can't. Can you go over that again?
Yes. So this is a good thing to know too, especially for this exam, because it's going to be in there one way or another. But this is a specific side effect for antipsychotic medications for schizophrenia. And so it includes abnormal and almost uncontrollable, like, facial and upper body movements. So it can look like shoulder shrugging or like neck twitching. Let me think, lip smacking, and even like rolling your tongue. And so once this starts, it becomes permanent. And so it's a really, really negative side effect of antipsychotic meds, which is why, you know, those are very closely monitored, because once that starts developing, we can't stop it.
Also, while we're talking about the medications, are you going to want us to know like specific medications at all, or just side effects and stuff like that?
So it won't be like specific medications, but it would be like, so if somebody has a phobia, what would be the best line treatment? Would it be meds? Would it be X treatment? Would it be Z treatment? Just kind of knowing generally what the first line treatment is. I won't have you break it down into like SSRIs are good for this. It won't be to that level, but just know generally, like, is meds good for this? Some disorders, yes, some not, and know the difference.
Okay.
Another thing with schizophrenia, just because this is such a complex disorder and there's so much that goes into it, know the different types of catatonic behavior. And so you don't need to know, like this might be a good thing to just have in your notes, honestly, but just being able to differentiate some of those symptoms, because there's likely going to be questions related to that. So what I mean by that is like rigidity, stupor, excitement, unusual motor disturbance, like those big things. I think there's like an entire slide on it within the psychotic disorders section. So just review that, make sure you know the difference between the two, or all of them, I guess. So I think that was the big tips I had for psychotic disorder. So does anybody have any remaining questions on psychosis in general, or just kind of lingering thoughts?
Did you mention the diathesis model earlier or something like that?
Yeah, yep. So that was one of the models to know. That's something that we've already covered in this class. So just generally knowing what that is and how that might explain some of the etiology for schizophrenia, but spend, time knowing the biological, psychological, and sociocultural so that you kind of can differentiate them. But the big things is like those two new things that I introduced with I can't remember, downward drift and social causation. So knowing those two and the difference between them.
Would you need to know like the different on the treatments? You'll need to know the biological, the psychological, and the social with the treatment as well. Are you going to get into that?
Just generally. So like not super specific, but you should know like for schizophrenia, what would be the first line treatment option for them? And it's biological, right? So just knowing when that would be first line versus when like psychotherapy would be first line. And then specifically, if we were going to, certain disorders like OCD, what would be the first line of psychotherapy for that? Because I spend a lot of time talking about treatment in that lecture. So just kind of knowing specifics to that extent, but not, like I said, types of meds or anything like that.
Okay. I don't have any more questions about schizo disorders. I don't know if anybody else is ready to move on or not.
Everybody good on psychotic disorders? Give me a thumbs up or thumbs down. Cool. Okay. So let me see what I have next. So for the OCD section, obviously know the difference between an obsession and compulsion. There's going to be, again, examples of this is what this person is experiencing. What is this? And so again, it's not going to be the definition, but being able to apply that definition and knowing the difference between the two. So that for sure will be on there. And if people need me to go over definitions, let me know, or just stop me, but I'm just throwing some stuff out there for you guys to consider. Another thing with OCD is Mauer's two-process theory. Know what that means, what that looks like, know the role of classical and operant conditioning. Just kind of go through, I go through an example discussing how something might be classically conditioned. I think it's like a doorknob example. Go back and look at that And then right after it, it's going to discuss, okay, well, there's this anxiety, right? So what do we have to do to remove the anxiety? And that's where the compulsion comes in. So just know generally what that looks like.
Are you going to talk about trichotillomania? Gosh, I can never say that whole word. The hair pulling one.
So it'll be on there, but very, very broad level. It's kind of lumped in with body dysmorphic disorder. So just, you know, don't spend a lot of time on that, but just do know generally what it is and how you might treat it.
Okay.
But that will, you know, those kind of disorders, just because they're more rare in general, we won't spend a lot of time on that. But yeah, it will be on there just in a really broad context.
Okay. And then with OCD, are you going to want the etiology of that too? Etiology?
Let me see. I think I'm less concerned with the etiology of OCD because we basically, it's going to be asked in regards to that Mauer's true process theory. So as long as you understand that, you're going to be able to answer that question.
Okay.
Because that's basically, you know, that goes through how it's, you know, developed and maintained, right? So if you can rationally talk about that, then you're going to know it.
Okay.
Other questions on OCD? That's literally the big things, knowing an obsession versus a compulsion, and then the Mauer's true process. It's what I want you to focus your time on.
You putting those like questions at the end again that don't necessarily count towards the exam grade?
Yep, there's 4 extra credit questions. Those range from stuff I talk about in lecture examples to video. So yeah, there's going to be 4 of them. And take a shot. Like I give half points sometimes if somebody's even close and they guess. So if you have an idea, just put something out there.
I guessed on one last time about what about the slip, the Freudian slip? It was like,
yeah. Mm-hmm. Yep, exactly. So, and sometimes even if it's just like broadly there, I'll give it to you. Like it's extra credit. So, but if you're watching the videos I have you watch and listening to my examples, you should be able to get these extra credit questions. So if not all of them, at least a few. All right, anything else on OCD?
Yeah, that was going to be my question. Somebody asked in the chat about somatic symptom disorders.
Yeah, so we will get there. I just want to make sure nobody has questions. Like that's a whole different lecture, right? So if we're good on OCD, we can go to the somatic. Everybody good? Okay. So my tips for the somatic symptom disorders, generally speaking, I would focus my time on kind of being able to differentiate the difference between somatic symptom disorder and illness anxiety disorder. Those, you know, they overlap quite a bit, and as long as you can distinguish what the difference is, that's going to be a really helpful thing. Does anybody know or want to take a stab at it?
Isn't like the illness anxiety, isn't it more like hypochondriacs? Like they think they have something, they keep looking for it. Whereas in the somatic, they really are experiencing that, and they're not like thinking, they're not actively looking for it. They just know that they're not feeling well, and it's the whole body somatically, right?
Yeah, so basically with somatic symptom disorder, they're not necessarily concerned about having an illness, right? They're basically focused on those specific symptoms. So that's exactly how you're going to differentiate it, because they're not worried about the meaning. They're worried about the symptoms. So they want, you know, they go to doctors because they have these different symptoms and they want it to get treated. They're not worried that this is like a bigger illness or condition that they have. They're impaired by the symptoms alone, where illness anxiety is, you know, they want the entire illness or condition taken care of. They don't care about any symptoms. They just want this big thing addressed. That's exactly it. That's how you tell the difference between the two.
There was a quiz question. I don't exactly remember what it was asking, but it had something to do with like what people do when they want attention. And I got stuck on that because malingering, isn't that just like money and drugs? Like you're getting some reward. So would that include attention or no?
So good question. So that's another thing you're gonna know, right? Malingering versus factitious disorders in general versus kind of the somatic symptom disorder. So first and foremost, malingering is not a psychiatric diagnosis or a psychological diagnosis. So this is basically when individuals are intentionally producing or faking symptoms, and they're motivated by tangible incentives. So things like money, you know, that kind of thing. So this is something that psychologists actually examine and test for, you know, especially when people are coming in with these huge things and a lot of different symptoms, and, you know, they want to get these benefits or, you know, different things like that. We have tests where we actually assess for that, but malingering is not a disorder. And so that's one, so just know that general definition. So then if we move on to factitious disorders, just generally speaking, these are, because, you know, we have factitious disorder and factitious disorder by proxy, right? So knowing that these are intentionally producing and faking symptoms, so similar to malingering, but not to receive that tangible reward. Instead, they want that sick role. So they want the attention. This was what we had, you know, used to term like Munchausen by proxy. So we either make ourselves sick or we make like our child sick. So that's what factitious disorders are. It's the same thing as malingering, but we're doing that for actual attention, and it is a psychological diagnosis. And then just generally speaking with like somatic symptom disorder, so just remembering that these people are not intentionally faking symptoms. So they truly, truly believe that they have these symptoms and that they're experiencing them. So just being able to differentiate that, because, you know, they're not faking it, right? They truly believe something's wrong, which is why that disorder is given only after a medical evaluation. So the other two they are faking, that one they aren't. Good question though. Does that answer it for you?
Yeah, thank you.
Does that make sense to everybody else?
I'm not sure if you're able to hear me.
Yep, we can hear you.
Working? Okay, perfect. Last Zoom call, it wasn't working. So illness, if it's okay, I just kind of, some of the symptoms versus somatic was a bit confusing. Illness anxiety, there are no symptoms, but they're always looking out for it. Is that correct?
So they might have symptoms, but they're focused on like this bigger thing, like, oh, I might have, you know, like a small headache or something. That must mean I have cancer. So I have cancer, and that's what I'm concerned about.
Okay, and then the somatic symptom. Yeah, and then the somatic symptoms, they do have symptoms, but they are just focused on trying to take care of like the headache or the pain. And then that's where I got
Yep, it is confusing, but that's exactly it. Somatic symptoms, they truly want to get those symptoms taken care of. So they're experiencing in them, and that's what's causing them distress.
And then conversion disorder, they don't have symptoms, but they're faking them, such as with the blindness, they can actually see, but they think they can't see.
Yeah, so let me come back to conversion disorder in 1 second.
Okay.
One thing I'm going to go back to just somatic symptom disorder really quickly. One thing that might help to, even when you're trying to understand it, is knowing the difference between that primary and secondary gain. So that's absolutely going to be on the exam in one way or another. And so just a reminder on that, you know, primary gain or benefits is kind of internal things, right? So that can be things, you know, like they're actively escaping or avoiding things that make them anxious, right? So getting sick, they get out of something. Whereas secondary benefits or secondary gain, that this is specifically relevant to all of the somatic symptom disorders, but it explains the maintenance. So, you know, like when people are sick, other people treat them a certain way, they may give them more attention, do things, these external things. So generally speaking, just know kind of the difference between primary and secondary. Does that make sense to everybody? Okay. And primary is often related to conversion disorder. So let me pull up, I just want to see what level of detail I want you guys to know for this. Can you repeat what you thought conversion disorder was again?
Yeah, I guess it was confusing when describing someone who thought they were blind, but they were navigating through the room. It sounded to me they don't actually have that symptom. They're not actually blind, but they think they are blind and they are responding to it almost like they are, but they also didn't care that they just woke up one day. So it was a bit confusing if they actually had a symptom that was caused by a disorder, or if it's a disorder thinking you have symptoms.
Yeah, so good question. So with this, there's no medical explanation. So they're likely not experiencing that symptom, because oftentimes whatever symptom they're describing is like incompatible with how our bodies work, right? So that example you were given with feeling, you know, blind, like I kind of talked about it in lecture where somebody might come in, say that they're blind, but then walk through doors and, you know, not be bothered by it and all, you know, X, Y, Z. So the symptom likely isn't there. It's truly like a psychological deficit that's happening because there is no medical explanation for that. But with conversion disorder, a lot of times it is kind of that loss or alteration of motor function. And so it looks kind of like, you know, maybe a medical condition or a neurological condition. So that's why they get, you know, these tests and all of that, but nothing comes of that, right? There's no physical explanation for that. So that's one thing to look for in conversion disorder, is because I think there's a slide on it where I kind of discuss the specific symptoms. So there's like 3 categories. It's like seizures, right? Those pseudo seizures, where even when they've done brain studies, they're not actually having a seizure. Motor symptoms or kind of deficits in that. So that's things like, you know, losing your ability to speak, or, you know, losing movement in your arm, that kind of thing. Or sensory, like you described, where it's like blindness or deafness. So look for those 3 categories specifically for conversion disorder.
Okay, thank you. Yeah, I think it was just confusing when it's called somatic symptoms for both of them, but one, they actually have headaches, and the other one, they're navigating a room thinking they're blind. So it was a bit confusing trying to get it into one definition of somatic symptoms.
Yeah, absolutely. And just like, yeah, trying to remember with conversion, like it really mimics like a medical condition, but it's incompatible. Like those symptoms truly cannot exist with how the person is acting, even though they might think it's true, right? So just kind of looking for, you know, if I give you like a vignette or something and it describes symptoms and you're trying to differentiate the two, look for, are they experiencing seizures? Did they lose, you know, sight? Then you're going to know it's conversion disorder.
Okay, thank you.
Mm-hmm. Yeah, good question. Those ones are really confusing. And they're hard to sometimes tease apart because sometimes people can't even, you know, articulate or verbalize their experience. And so it can mimic these different things. Other questions on that or conversion disorder? Does anybody know what La Bell indifference is with conversion disorder specifically?
Would you mind going over that, please?
Yeah, it's at its most basic and simplest form. They just don't care about their symptoms, right? They're not concerned with it. So someone might say like, yeah, I can't see, I'm blind, but well, that's, that it is what it is. No big deal. This is my life now. And so it's just kind of that indifference of not really caring that you're having these major, major symptoms. And it's just kind of, it just kind of goes to show that this is truly a psychological disorder, right? Because if it was a true physical manifestation, they likely would experience some distress from that.
Okay.
Yeah, good job in the chat. Yeah, exactly it. So do know what that is generally. Anything else with the somatic disorders? People feeling okay about that? I know they're tricky, but the questions, aren't designed to trick you. So if you generally know them, I think you can make a pretty educated guess. All right, let's go to, let me see what I have next. So dissociative amnesia, how do people feel about that?
So there's different types though, right?
Yes.
So like how much do we need to know about that? Like,
so know the types. You're going to want to be able to differentiate because again, it's going to probably be some type of vignette explaining, this is what somebody's experiencing. What type of dissociative amnesia is this? So, there's the 4 types that I want you to focus on. So localized, selective, generalized, and continuous. So knowing those 4. Do you want to go over them now? Do you guys just want to study them on your own? I'm fine with whatever. Anybody have a preference?
can we go over them?
Yeah. Yeah, we'll just go over them quickly. So localized, this occurs when the person loses memory for like a whole specific time period. So this is usually during or immediately after a traumatic event. So they can remember information before and they can create new memories following it. So that's all intact. It's just either during or that time period right after. So that's why it's localized. So selective, this is where, people can remember some, but not all of the information from a specific time period. So again, this is gonna look similar to localized because it's gonna usually be during or immediately after, but it's just really small. So it's just kind of pieces of that. Generalized, this occurs when the person can't remember anything at all from their life. And so this one will be really obvious. So they don't know who they are. They can't remember anything from their childhood. They have no recollection of anything. I think I gave, an example in lecture about like a woman that, experienced kind of a traumatic event when she was separating from her husband. And then she went to a neighboring town and like her husband found her 2 months later and she went by a new name, had no idea she was married, that kind of thing. Like it's a complete loss of identity. And then the last one is continuous. So this occurs, when a person cannot form any new memories after the trauma. So this is the one, you experience a traumatic event and then after that you can't create new memories. You're kind of stuck. So knowing just those basic, sorry, what was that?
So traveling is a specifier, right?
Yep, dissociative fugue. Yep.
Yeah,
Knowing
so
kind of
generally any of those.
Sorry, what?
That can happen along with any of those specific types. Okay.
And that one's going to be, really, really specific. If you're going to see that, you'll know. The other ones are a little bit harder to tease apart. So just kind of knowing the general difference between them. But yeah, knowing that traveling piece too. because kind of, you know, that situation that I described with, you know, the woman going to the other town. So technically she'd have that and she'd have the dissociative fugue because she did travel, you know, she lost that important autobiographical information. So that could technically be both. Does that make sense to everybody? So there will be, you know, some type of short little vignette describing that. So just be able to tell which one's which. Okay. So next, so generally speaking, kind of know, you know, I spent some time talking about it in lecture, and it's you know, controversial. It's a really rare but difficult disorder. So DID, there's not going to be a ton of questions on it just because it's a really, really hard disorder to study. So what I'm going to be looking for is just knowing kind of the different etiology theories related to that. So just generally speaking, kind of if somebody has it, what might cause it, right? And so the two big ones that I discussed in lecture were that post-traumatic theory. So that's basically just saying that DID starts, right, in response to some type of severe trauma. And so this typically is in childhood. So I think it's like 90% of, you know, individuals with DID did experience some type of extreme trauma as a child. And so they aren't able to, like, because oftentimes it's the parents or somebody close to them, so they aren't able to like report the trauma or get that social support that they need. And so essentially their brain just kind of creates this other identity that can be like the stronger identity so that it can handle the stress and deal with the trauma when it happens. So that's that post-traumatic theory. Whereas the other theory, sociocognitive theory, this basically is just saying that, you know, DID can occur after, you know, maybe a really well-meaning therapist. They might have, you know, a big interest in DID, and they basically inadvertently suggest that this person might have multiple identities. And typically this occurs when somebody's under hypnosis. It would never, you know, work if it was just in a regular therapy session. But then again, like, so people might believe they have DID, they might act like it, even though they don't have the disorder. So basically they're kind of told these things and then they believe them because of that. Does that make sense? Okay, so know those two theories. Again, DID is it's not going to show up a lot on this exam because it's a tough one, but just knowing kind of generally the etiology. All right. We good on that lecture? Feeling okay? Any other remaining questions? Seeing some thumbs up. Okay. So the last one is just anxiety disorders. And I know that feels like a lifetime ago. So I even forgot that that's what we started with. So making sure there's a lot of disorders we covered in there, right? So knowing generally what the presentation of those disorders look like. So just make sure you go back and spend some time on that because that was a pretty lengthy lecture and there's a lot that's involved in that. So just being able to differentiate those disorders at the most basic level. So that's a good place to start. Another thing that is probably helpful to know is treatment. And so that can look very different depending on what disorder you're discussing. But one thing I would suggest focusing on is treatment for phobias specifically. So does anybody remember, and I'm not trying to put anybody on the spot, but does anybody remember what that looks like?
The exposure therapy, isn't it?
Yeah, essentially. So it's systematic desensitization. So that's the big thing. And so it will be exposure, and that can be, you know, gradual or flooded. It can be in vivo, so in person or imaginal. And then that exposure, exactly like you said, paired with relaxation. So I think I go over, you know, quite a few examples with that. But just be, you know, know that that's generally how you treat those. So this is going to be one that it's not necessarily like it could come up in multiple choice, but no, this is where you're going to want to be able to describe fully for writing out an answer. So I'm basically giving you a tip to study on here, but know how to treat, right? Know how to treat phobias. So there's a lot of different ways for that. And what I suggest focusing on is knowing what role classical conditioning plays when we develop phobia. So start at the beginning. How does this develop? Kind of watch those examples that I give, especially when I'm talking about true alarm and false alarm, because that's basically how these things develop. And true alarm and false alarm are things that you might see in multiple choice questions as well. But no classical conditioning, because that plays a huge, huge role. And then I go through kind of other different ways that phobias can develop. And those are things like vicarious learning and information transmission. So those are 3 big areas to focus on in the development of phobias. Are you also with me so far? Okay. So be really comfortable with that. This is, we spend time on classical conditioning, operant conditioning at the beginning of this class, but specifically for phobias, classical conditioning plays such a big role. And so being able to, if somebody has a phobia of snakes, be able to describe how that could develop, right? Use that terminology, be comfortable with it. And so just kind of practice that, review my lecture on that specifically. And then if you know the difference, so, here's classical conditioning, here might be an example of vicarious learning. And so this, just as a reminder, this is kind of when phobias develop in situations that we've never experienced before. So classical conditioning, it's where we've had direct experience with that stimulus. So whether that's a snake, whether that's a plane, whatever the case may be. Vicarious learning, we haven't actually had that experience. And so we watch others, right? They behave in anxious ways. They look scared. They're fearful. That is how vicarious learning happens. And so that's basically watching. And then the only difference between that and information transmission is that someone tells us about how they behaved anxiously or they were scared, right? So they told us how they reacted to that stimulus. And so that's how we start to kind of make that association. Good so far? All right. Okay. So one note with, learning phobias through vicarious learning and information transmission too, is that we have to be made aware of what that actual response was, not just the stimulus. So we can't just be, oh, it's a snake, that's what I'm afraid of. We have to know that that fear was involved. And so hearing someone say that, that someone got bit by a dog doesn't make us afraid automatically. We need to know that, witness this person in fear. We need to see the response after the bite or how they told us that they responded after the bite. So just making sure that you make that connection as well. All right, so then with kind of back to that, exposure treatment for phobias, typically through systematic desensitization, the person, you kind of use like this step-by-step method, right? So that you expose this person to whatever that phobic stimulus is so that their anxiety response decreases. And so this is where you can kind of go into, looking at if it's real life, it's imaginal. There's really specific examples of, I think I go through it in lecture where here's a fear hierarchy, right? This is where we're going to start. So we're going to gradually expose you to the stimulus so that you get desensitized to it, right? Like it doesn't produce that same feared response. And so just knowing kind of generally how you might treat somebody for that. Look at that. I think it might be a dog example. I can't remember exactly which one I used, but looking at that fear hierarchy, and that's how you would kind of, explain that as well. And so the only difference too, and you don't have to get this specific, but sometimes it's helpful, is just knowing with graduated, that you expose, you know, the person to the less fearful. And so you slowly move that up that fear anxiety list hierarchy until they kind of master those lower components. But if they needed, you know, something really quickly, like if they were afraid of flying and they needed to go on a plane next week, you would use flooded. And so that's where you're starting at the most distressing one and just kind of exposing them immediately. Does that make sense to everybody? Okay. So generally knowing that, spend some time reviewing it, be able to talk about it, review those examples, exactly how kind of I discuss them in lecture. That's ways that you can talk about these things too. Okay. So I think that was all the prepared stuff I had. So if anybody else has any other remaining questions, you can throw them out there. You can always email me too. Like I said, you have, you know, until Sunday evening to take this. So keep me posted if things come up, but I hope this was helpful. This is something we can do for the next couple. If people are interested, let me know, and, you know, I'll send out more announcements and stuff too. So